Good evening, dear friends. I welcome you all on behalf of AOGGIS AOGGIS to this meeting, our monthly meeting. And I'd like to invite our president, Dr. Archana Kannan, for making call.
Good evening, everyone. Meeting is called to order, and I would request Dr. Sudeep to read out the minutes of last meeting.
Our last meeting was held on 7th October in the same venue, and it was an international seminar on infertility in which we had Dr. Marcus, Dr. Surveen Burman, and Dr. Nisha Bhatnagar as our speakers. And today's meeting shall be a panel discussion, and the topic shall be thyroid disorders in pregnancy. And to start the meeting, I would like to invite our treasurer, Dr. Richa Gangal, to have her seat on the dais. Dr. Nishi Agarwal, our joint secretary, please have your seat on the dais. Before we start with our panel discussion, there is a small topic on hyperandrogenism, and I'll like to brief that topic in just 10 minutes because we have our sponsors MDS Organon who have their pill with cyproterone acetate, and they want us to focus the role of cyproterone acetate in hyperandrogenism. So I shall be taking the talk, and before that I'll ask Dr. Nishi Agarwal to kindly take out the punctuality. I request Dr. Gayatri Singh ma'am. Please do the honor. You are special today. Dr. Ranga. Our Vice President is also with us. You please have your seat on the dais. Dr. Poonam Singh. So here's a brief talk on hyperandrogenism and then we shall start with the panel discussion. थोड़ा सा lights dim. So what is hyperandrogenism? As we all know, androgen excess is hyperandrogenism, and it affects about 5 to 10% of women in reproductive age group. We are commonly encountering PCOS, polycystic ovarian syndrome, which is prevalent among 80 to 85% of the women with androgen excess. What are the clinical signs of hyperandrogenism? Hirsutism is a common manifestation of hyperandrogenism, and other clinical signs, as we all know, are acne, seborrhea, androgenic alopecia, male pattern baldness, as we all say. And depending upon the degree of androgenization, we have various signs of viralization also in the patient. What is hirsutism? Excessive male pattern, that is terminal hair growth in women, is called hirsutism. In patients with hyperandrogenism, about 15% of the women will present with hirsutism. It results from increased androgen production and maybe because of increased sensitivity of pilosebaceous unit to androgens. It is observed in 70 to 80% of the patients with hyperandrogenism. It leads to significant psychological morbidity and it can also negatively influence the quality of life. And this is a Ferriman Galway scale. अभी तक हम लोगों ने कभी पढ़ा नहीं था कोई scale scoring के लिए hirsutism का. So I am telling you, these are 9 body areas, and in this the presence of the from 0 to 4 depending, and 4 is the extensive terminal hair growth. Answer is about 25% of the patients who are asymptomatic, similar in size, no mature follicle is seen. According to NIH 1990, there should be chronic anovulation and clinical signs of hyperandrogenism. According to Rotterdam, they should have oligo or anovulation along with biochemical signs or clinical signs of hyperandrogenism. Plus, they should have polycystic. PCOS Society said that clinical or biochemical signs of hyperandrogenism along with ovarian dysfunction in any form, oligo and anovulation or polycystic or any ovarian morphology shall be classified as. We'll deal with management of hyperandrogenism. What is the role of combined oral pills? Options and therapy basically either inhibit the androgen production from ovaries, which can be done by the use of oral contraceptives or GnRH analogs action. That can be done by anti-androgens like cyproterone, flutamide, spironolactone, and also 5-alpha reductase inhibitors like finasteride. Also, we have insulin sensitizers we are commonly using metformin and thiazolidinedione. We'll be concentrating more on combined oral pills. First generation pills we are no longer using. Generation OCPs have low androgenic activity as compared to first generation. They also have a very low androgenic activity, so our purpose is not solved. We use pills with drospirenone as a combination. Drospirenone is a derivative of spironolactone. It has anti-androgenic effect as well as anti-mineralocorticoid effect. So it improves the signs of hyperandrogenism and also it alleviates the estrogen-related fluid retention. Cyproterone inhibits the binding of dihydrotestosterone. This is the activity of the enzyme 5-alpha reductase that catalyzes the transformation of testosterone in dihydrotestosterone. So we have less active testosterone levels in the are there any guidelines to start hormonal treatment in acne if the woman have acne flare-ups before menstruation? Like the patient has not started menstruation in many years and she is having acne. Or when we require oral contraception also along with acne treatment, then also we can give sexually active and we are giving her isotretinoin treatment for acne. We do not want her to become pregnant, then also we can give OCPs. In women who has alternative when repeated courses of isotretinoin are needed, or in women whose acne is not responding to conventional therapy we have already given, or in the woman with acne as well as PCOS syndrome, or in the woman with clinical signs of hyperandrogenism, as we all know, androgenic alopecia and hirsutism and all, and or in the woman with late onset acne. And we can also give hormonal therapy in women with proven ovarian hyperandrogenism and in patients with proven adrenal hyperandrogenism. So these are the indications for using hormonal treatment in hormones. Should however rule out ovarian and adrenal tumors, and hormonal therapy should be acceptable to the patient. Many of the adolescent girls they say कि हमको oral pills नहीं खानी है. अगर हमारे parents हमारे पर्स में pills देखेंगे तो सोचेंगे कि ये क्यों खा रही है. So hormonal therapy should be acceptable to your patient also. Then only you should start it. And now in the management of hyperandrogenism in toto, what is the role of oral contraceptive pills? We'll be concentrating more on cyproterone pills in many studies, but they prove that in treatment, when we have treated patients with cyproterone acetate pills, there had been significant reduction in acne in the 4-cycle treatment and also significant reduction in the hyperandrogenic signs and symptoms. So our conclusion is that a combination of cyproterone acetate 2 mg with ethinyl estradiol 35 microgram, which has a very low steroid content and has got few side effects and has excellent effect on acne. It seems to be a method of choice for the woman with acne who can accept oral contraception. Studies showed that it is helpful in reducing the hirsutism also, like the coarsening of hair has reduced and the thinning of hair has happened, and even the female curvature has set in. Brain reviews also goes in the favor of use of cyproterone acetate. At the end, I would like to say that oral pills that contained cyproterone acetate improve acne better than levonorgestrel pills, and drospirenone combined pills appear to be more effective than norgestimate and nomogestrel combinations. And combined pills with cyproterone acetate showed better acne outcomes than with desogestrel. We often get confused that, like if I already told you, the patient is not accepting hormonal therapy. So is there any way out? Then we can give patient metformin, as well as we can advise her lifestyle changes. But is there any guideline to follow? Yes, there it is. If the patient is oligo or amenorrheic adolescent, then we have to classify her as having PCOS or not. If the patient is having PCOS, then we should do her clinical and lab assessments, like sexual history we should take out, we should get her BMI done, and do our oral glucose tolerance test done, and tests of hyperandrogenism also to be done. So if the patient is sexually active, we can safely put her on OCPs. That will solve all her problems. But if the patient is overweight and obese, then we can have a choice of putting her on metformin, or by lifestyle modification also we can improve her oligomenorrhea and amenorrhea. And if the patient is having abnormal glucose tolerance, then we should always think on putting her to metformin. And if the patient is hyperandrogenic, we have already learned that OCPs are going to be of great help. So in the end, I would like to conclude that these MST organon people are having a drug with cyproterone acetate and ethinylestradiol in the right concentration, which can be very safely used for your patients with acne as well as hyperandrogenic. Thank you so much.
Very nice talk, Dr. Sudeep. Thank you so much.
So I would like to invite Dr. Archana Tandon to start our panel discussion, which is on thyroid disorders in pregnancy.
So good evening everyone and welcome. I'm really happy that all members are cooperating to the best of their level and accepting email and WhatsApp notices in good spirit. So in February, we plan an activity on our project, Revere the Girl Child, and we are working it out how we shall proceed with that. So if any one of you has any ideas, you can send me your ideas on email or on your letterhead, whatever suits you. In March, we have our annual CME on 19th and 20th March. And we'll be publishing a journal. Dr. Uma Bharatwal has already posted a notice regarding it, and an email too has been sent to you all. And also, I want to ask if all of you are ready for infertility classes with 10 modules, each module taken up in each month at a stretch. So those who are ready for that, Max will be holding it. Please raise your hands. So yes, everyone agrees. So we start those infertility classes from April onwards. Every month we'll be having, and for the first hour we'll have their infertility classes, and the next hour will be an academic session by our own society. And of course, all those who are interested in any other panel discussion or any other activity that you have in your mind, you can send me the ideas on my email address or on your letter pad. Everyone is welcome to give the ideas. Now I invite the panelists to take their seats. Dr. Sangeeta Madan, Dr. Uma Bharatwal, Dr. Poonam Singh is already there. Dr. Sarika Sirohi, Dr. Ruby Chugh, Dr. Archana Kumar will not be coming. She has an emergency case with her. So Dr. Nishi Agarwal is already there. Dr. Manisha Jain, she is not here. Dr. Divya Goyal, Dr. Kajali Gupta, and this is our page AOGGIS. So there's a like button here and you can like it, and then you'll regularly get in feeds of all the photographs of all the activities that we do here. You can all view the photographs of our previous meetings over there. So now we all are welcome, and AOGGIS classes presents its first thyroid disease in pregnancy panel discussion. Welcome everyone. Thyroid disease in pregnancy. Science is a ever-changing branch. So what the questions are answered today, we find the answers, but then the question changes. So we proceed from unanswered questions to questionable answers. And I would request all of you to maintain silence in the hall and switch off your phones. So, Dr. Poonam, how do thyroid function tests change during pregnancy? Yeah, definitely.
As soon as the pregnancy is commenced, the thyroid binding globulin that increases, and it causes about 1.5-fold increase in T3 and T4. And the increased requirement of T4 may be due to transplacental passage of T4, degradation of T4, and increased glomerular filtration rate that occurs in pregnancy. That increases the iodine clearance from the body of the mother. So these are the changes in thyroid functions.
So you mean to say that physiological increase in iodine requirement is there during pregnancy?
Yes.
Then there is an increase in T4 levels in pregnancy, which is also physiological. And because of this T4 increase and the action of HCG on the receptors of thyroid receptors, there's increased that reduces the level of TSH.
Yeah, they same that they share the same structure.
Same structures.
So as the HCG goes on increasing, the TSH goes on decreasing as the pregnancy advances.
Right. Thank you, Dr. Poonam. So we proceed to the next question, and we go back to school, because when causes are asked, I remember school. So Dr. Sangeeta, please take us back to school. What are the common causes of hypothyroidism?
Main cause in our country is iodine deficiency and Hashimoto disease, head and neck area, or radioactive ablation of thyroid before that. And some medicines also causes hypothyroidism, such as anti-cancer drugs, interleukin, lithium, and thyroid surgery for thyrotoxicosis also causes hypothyroidism later on.
Thank you, Dr. Sangeeta. We proceed to the next question. There's a big diagnostic dilemma, and Dr. Sarika, I would like you to answer, because all the obstetricians are in a big dilemma. Whether should every antenatal patient be screened during first trimester or not?
Yes. To these questions, there are various recommendations according to various associations and societies. According to the American Thyroid Association, they do not recommend thyroid TSH screening in the first trimester. They recommend neither for nor against the TSH screening in first trimester. But they clearly state that FT4 screening, universal FT4 screening is not required during pregnancy. Then coming to the Thyroid Endocrinological Society, it also does not recommend universal TSH screening, but it do recommend the TSH screening in high-risk individuals. And it also promotes the prenatal low-dose levothyroxine therapy with a target of TSH of less than 2.5 milli international unit per liter. Then coming to the Indian Thyroid Society, the ITS guidelines, it clearly states that every pregnant patient should be screened for TSH at first antenatal visit. And they also promote, uh, they clearly states that ideally every patient should be screened for TSH during pre-pregnancy evaluation or as soon as the pregnancy is confirmed. Due to somewhat higher incidence of thyroid receptor antibody positivity in India, it would be very prudent for all of us and for all healthcare providers that we should follow ITS guidelines and we should go for universal TSS screening. And we should also involve the patient in our decision making so as to satisfy her, and we may explain her that why it is necessary for her and for an unborn child, and we may thus prevent the discontent regarding TSS screening. Thank you.
Yes, very appropriately put in. So, for us Indians, all patients should be screened pre-pregnancy and during pregnancy. Dr. Archana Kumar is not here, so I put up this question, and any of the panelists can take it up. What is the normal range for TSH in each trimester? Dr. Ruby Chug.
Normal TSH level during first trimester is 0.1 to 2.5 milli international unit per liter. During second trimester, 0.2 to 3 milli international unit per liter, and during third trimester, 0.3 to 3 milli international unit per liter.
Dr. Divya Goel, what is the optimal method to assess FT4 during pregnancy?
There are two things to remember. For any test, we have a gold standard and we have a clinically applicable method. When we talk about a gold standard for FT4, it is equilibrium dialysis. But it is not possible to apply it in our daily practice. We use it to set reference ranges. We cannot use it for our daily clinical use. They are expensive, time consuming. So what we use is immunoassays. There is a lot of discussion about immunoassays that they have a lot of setbacks. They have a lot of shortcomings. But right now the American Thyroid Association says that we can use FT4 by immunoassays provided we have to ask the laboratory that please give us the method specific and trimester specific ranges. So this is for all of us to remember. Wherever we are getting our reports from, we make sure that the laboratory is giving not only method specific but also trimester specific ranges, and we take it with a pinch of salt. There are new techniques which are being developed on the principle of equilibrium dialysis, like liquid chromatography, tandem mass spectrometry. They are being done in some very tertiary centers, not even in India. But there is going to come a time within 3-4 years, anything that comes within 3-4 years, it becomes more affordable. So probably after 4-5 years, we would be doing something comparable to equilibrium dialysis. So right now we have immunoassays, which is the best choice for us. And take it with a pinch of salt that this FT4 by immunoassay might have its own shortcomings. Thank you.
Thank you, Dr. Divya. So we have to rely on immunoassay till chromatography comes in. Dr. Ruby Chug, what are the definitions of overt hypothyroidism and subclinical hypothyroidism in pregnancy?
Overt hypothyroidism is defined as elevated serum TSH level more than 2.5 milli international unit per liter in association with decreased FGF4 concentration. Women with a TSH level more than 10 milli international unit irrespective of their FGF4 concentration is also defined as overt hypothyroidism. And subclinical hypothyroidism is defined as elevated serum level TSH level between 2.5 to 10 milli international unit per liter with normal FGF4 concentration.
Thank you, Dr. Ruby. Dr. Uma Bharatwal, how is isolated hypothyroxemia defined in pregnancy?
Isolated hypothyroxemia is when TSH level is normal, that is less than 2.5 milli international unit, but FT4 concentration is lower than 5/5 percentile. TSH, normal TSH level is must in isolated hypothyroxemia, but free thyroxine level is lower than normal.
Yes, because in subclinical hypothyroidism you have lower TSH and lower T4. But in isolated hypothyroxemia, you have normal TSH and only T4 is decreased and lies between 5th to 10th percentile. SCH हुआ तो खतरे की घंटी बजी. Now, Dr. Manisha Jain, could you enlighten us कि overt hypothyroidism में जब खतरे की घंटी बजती है तो what are the adverse outcomes?
With overt hypothyroidism, there are many detrimental effects which can occur in baby and mother also. Regarding fetus, it has found that there is detrimental effect on neurocognitive development of the child, of the fetus, and there is 60, according to one study, there is 60% rise in rates of miscarriage, preterm deliveries, low birth weight babies, and not only this, there is increased risk of fetal death in utero. Regarding mother, there is increased risk of pregnancy-induced hypertension and increased risk of preeclampsia. So, in conclusion, there is a strong association between adverse effects by this overt hypothyroidism.
Thank you, Dr. Manisha. Dr. Uma Bharatwaj, what adverse outcomes are associated with subclinical hypothyroidism in pregnancy?
In subclinical, if mother is having subclinical hypothyroidism, then the newborn may be having delayed neurocognitive outcomes, delayed milestones, etc. All the
Yes.
In these babies, there will be delayed milestones.
Yes, this is plausible, but it has not yet been demonstrated, and more studies are required for this. So that is why the American Association says that you don't have to treat subclinical hypothyroidism till you have associated T4 level decrease below 5th percentile. But in Indian conditions it does not suit because we have iodine deficiency and also other factors like tests are costly of antibody. But Dr. Divya will tell you now why we can do antibody also. Dr. Poonam, so there's a big dilemma to treat or not to treat subclinical hypothyroidism. So because one association says something, the other association says the other thing. So how do we do this balancing act?
I think if the TSH level, our aim should be to maintain the TSH level between 0.5 and 2.5 milli-international units per liter. If the TSH increases, so we should start levothyroxine to the patient, and if it is below 10 milli-international units, we should start at least 2 milligram per kg of body weight, 2 microgram per kg of
about
body weight.
10.
Yeah, if around 10, if it is around 10, and I think this is the aim to keep this TSH level. We should concentrate more on TSH between 2.5 and 2.5 milli-international units per liter.
Again, there is a difference of opinion. All subclinically hypothyroid patients with antibody positivity, that is TSH more than 2.5 and FT4 above 5%, but TBA thyroid antibody positive should be treated. This is said by American Association. So ATA guidelines do not address a situation for a situation like in India, which has challenged clinical setups, and people cannot afford the costly antibody testing because in urban areas we can get it done, but in rural areas and poor population, where it is very it is costly for them, Indian guidelines and the endocrinological society sets up different criteria, and they say that anyone with TSH between 2.5 and 10 should be treated with levothyroxine. So the Thyroid Association says that the Endocrinological Association says that start with 50 micrograms. And Indian Thyroid Society says that you start off and then monitor. Once TSH to be done, that will come later, when to be done.
TSH should be repeated every 2 to 4 weeks till the mid trimester of the pregnancy, and afterwards then 8 weekly we can do it TSH. So
yes, that is also there. There also lies a big difference between all the societies. American society says something, the Endocrinological Society says the other thing, and Indians are, because we are a society which is not the developed. We don't belong to the developed world, so we cannot do every 2 weeks. We cannot tell the patient for every 2 weeks. So we have a different criteria. We do it once in every trimester. That we'll be covering later. So Dr. Divya, can you throw some, since we just discussed thyroid antibodies and about Indians scenario, can you throw some light on thyroid antibody testing and its importance in pregnancy? Also tell us the cost incurred.
As rightly mentioned by everybody, we work in a very challenged clinical setup. We first have to think about the cost that will come to the patient and how necessary it is. I don't think anywhere in the world so much thinking about cost, medical cost goes in our country. So,
no,
but
one
advantage.
one round to the villages, and you'll one round to the PHCs in the villages, and that cost factor
just
enters your head.
Just in there in the back of the mind. So, but also all the panelists mentioned that one of the major causes of hypothyroidism is Hashimoto's in India. It is known. Okay. So I wanted to share this paragraph, which is given by American Thyroid Association, that 10 to 20% of all pregnant women in the first trimester of pregnancy are TPO or TG antibody positive and euthyroid. Okay, they are antibody positive and they are euthyroid also. So when they will come for antenatal visit, we will see a normal TSH. We would probably see a normal FT4 also, and we can say, oh, probably this patient is not hypothyroid, but probably this patient is anti-TPO or anti-TG positive. So then 16% of the women who are euthyroid and positive for TPO or TG antibody in the first trimester will develop a TSH that exceeds 4 MIU per liter by the third trimester. Okay, and 33 to 50%, 50% is a very huge number. 50% of women who are positive for TPO or TG antibody in the first trimester will develop postpartum thyroiditis. So that means what we see is only the tip of the iceberg if we are not doing antibodies. Because the onus now is not just to diagnose hypo or hyperthyroidism, but also subclinical, not just overt, subclinical. Because we know that TPO antibody positivity is also associated with a very high risk of preterm deliveries. So it is very important that if the patient can afford in the first trimester, afford is one of the things. Sometimes the patients can afford. We should do, if we do not do both the antibodies, at least TPO antibody, because TPO antibody is very highly suggestive of Hashimoto's. So at least we are mentally prepared that we have to do a more frequent screening of TSH for this patient. वो euthyroid है, अच्छी बात है, TPO positive है. So we cannot just let the patient go. Maybe after 6 weeks. No, normally we say, अच्छा 24 weeks पे we will get it done. If the patient is, यहाँ पे तो it's like if TSH is okay, once we say ठीक है, because patients can't afford. But at least 6 weeks to 8 weeks after that, we have to keep repeating in bed. And we have to be very, very careful in the third trimester, because then the TSH suddenly shoots up. And postpartum, we will not know what happened to the patient. The patient will go into postpartum thyroiditis. He was actually anti-TPO positive, which we didn't know. So if the patient can afford, we have to do an anti-TPO test, an anti-TG test, and it is, I would not say very cheap, and I would not say very expensive. It is somewhere in between. So if I don't know the cost,
yes, I want to know the cost. If you will not tell, then my next question will be, what is the cost?
Okay. Now, if we do an anti-TPO and anti-TG body khali ek karayenge, then it's 900 rupees. And if we get both done, it's a panel, thyroid antibody panel, then the cost comes down to 1400. We can get both the antibodies. So it's not very costly. Some patients can afford it. So it's always better to know It's a very important cause of, we see 50% of women will develop postpartum. This is American data. We don't even have our data properly because we are not doing anti-DPO antibodies that much.
Indian Thyroid Society has managed this part very well by saying that every patient which is subclinical hypothyroid, that is her TSH ranges from 2.5 to 10, has to be given levothyroxine, so that danger of antibodies producing complications is covered by treating everyone. So all those patients who can afford, you can, of course, it is better to get it done, and then frequent monitoring, as Dr. Divya said. And those who cannot afford, you can safely manage them by by giving levothyroxine, and you are safe. As further the questions will come and the answers will come, you will come to know that no complications have been observed if the patient's subclinical hypothyroid patient is being treated. So, Dr. Sangeeta, should overt hypothyroidism be treated in pregnancy?
Of course, overt hypothyroidism should be treated. That is, all the patients having TSH more than 2.5 and low FT4 level should be treated. And if TSH is more than 10, whatever it is concentration of FT4 should be treated. And even subclinical hypothyroidism with positive thyroid antibody in pregnancy.
Thank you, Dr. Sangeeta. Dr. Sarika, should isolated hypothyroxemia be treated in pregnancy?
Isolated hypothyroxemia, as previously said, it is a condition in which TSH is normal with decreased FT4. It should not be treated in pregnancy because till date it has not been found to be associated with any adverse effects during pregnancy.
Thank you, Dr. Sarika. So, Dr. Archana Kumar is not here. This question is open to all the panelists. Whoever wants can answer. I would like you to revise the treatment plan of subclinical hypothyroidism in pregnancy so that it gets drilled into our brains and we are not confused like this person. So, any one of you revise the treatment plan of subclinical hypothyroidism in pregnancy? Anyone?
Should I?
Yes, definitely.
I think as soon as the pregnancy is diagnosed, in our Indian patients and Indian scenario I'm talking about, as soon as the pregnancy is diagnosed, one should go for TSH. If the TSH is between 0.5 and 2.5, there is no need of treatment. If it is more than 2.5, then we should start with the minimal doses of levothyroxine to our patient, and the repeated monitoring should be done in these patients. Because the requirement for levothyroxine, it fluctuates during pregnancy, as HCG is also acting on the same receptor as TSH is acting. So I think it's necessary to repeat TSH at least every 4 to 6 weeks.
That will cover. So again, subclinical hypothyroidism, we have revised it a number of times over there, that all the associations give different criteria. American Thyroid Association says only if TPO anti-thyroid antibody positive cases are to be treated, and if antibody negative and if FT4 is below 5th percentile, then they should be treated. And they do not say for or against treating the other cases. Indian Thyroid Society says treat all subclinical hypothyroidism irrespective of thyroid antibody positive or negative, and the endocrinological also says give 50 micrograms levothyroxine to all. Dr. Ruby Chug, if provided, what is the optimal treatment of overt hypothyroidism or subclinical hypothyroidism?
The optimal treatment for maternal hypothyroidism is oral administration of levothyroxine, and it is strongly recommended that not to use the other forms of thyroid preparation such as T3 or desiccated thyroid.
Thank you, Dr. Ruby Chug. Dr. Manisha Jain. When provided, what is the goal of overt hypothyroidism and subclinical hypothyroidism treatment?
When provided, the aim should be to normalize TSH levels to the trimester specific range which has been provided, like for first trimester it should be between 0.1 to 2.5 MIU per ml, and for second trimester it should be between 0.2 to 3 MIU, and for the third trimester it is between 0.3 to 3 MIU per ml.
Yeah, thank you. This is also an open question. If pregnant women with subclinical hypothyroidism are not initially treated, so a woman comes to who has not been treated for subclinical hypothyroidism, she is pregnant, what is the key to monitor them through gestation? Anyone?
Again, it is according, that different societies says different things. Actually, the American Thyroid Association says that it should be monitored, TSH should be monitored every 4 weekly till second trimester, 16 to 26 weeks, and it is must to do it between 26 to 32 weeks. And Thyroid and Endocrine Society says that there should be monitoring in each trimester every 4 weekly. But Indian Thyroid Association says that TSH should be tested in such patients in only those who have antibody is positive. So it is must to do it between 26 to 32 weeks and 4 weekly in first trimester.
Right. Again, this is directed to Dr. Nishi. How do treated hypothyroid women receiving LT4, they are receiving levothyroxine, differ from other patients during pregnancy? What changes can be anticipated in such patients during gestation?
Clinical studies have confirmed that the requirement of T4 increased as early as 4 to 6 weeks of pregnancy. It increased till 16 to 20 weeks, and then it become plateau and till the delivery. So we have to adjust dose of thyroxine according to patient's TSH level.
Thank you, that was perfect. Dr. Poonam, what proportion of treated hypothyroid women receiving LT4 require fine tuning of LT4 dosing during pregnancy? What proportion of treated hypothyroid women, patients who are on LT4, require fine tuning of the dose of LT4 during pregnancy?
I think 80 to 85% of the patients they require.
So such a high proportion requires fine tuning for LT4. So that there is a great likelihood that dose increase will be required, and you have to be very particular in cases in patients who have undergone radioablation or surgery for thyroid disease and patients of Hashimoto's thyroiditis. There you have to be more careful. Dr. Sangeeta, in treated hypothyroid women receiving LT4 who are planning pregnancy, how to focus to adjust the LT4 dose?
The dose requirement increases in 50 to 85% of patients. T4 level increases. T4 requirement increases. It increases by 25 to 35%. So by adding 2 tablets, whatever dose she is receiving, 2 tablets per week, increases the dose by 29%. Or daily dose can be increased by 25 to 30%. Suppose she is taking 100 mcg, it should be increased to 125. Or if she is taking 100 mcg daily, it can be added to 2 tablets more can be added every week, 2 tablets on Saturday and Sundays.
The next question, Dr. Nishi. In treated hypothyroid women receiving LT4, what advice should be given to them if they are planning pregnancy? So a non-pregnant lady comes to you and she is receiving LT4, and she asks you, doctor अब मैं pregnant होना चाहती हूँ, मुझे कोई special precaution तो नहीं लेना, so what will you advise her?
Her TSH should be under control, and that is, it should be less than 2.5 million international unit per liter. Ideally, it should be less than 1.5.
Yes, if you reduce it to below 1.5, then you will get a better control when she becomes pregnant. So if you can get it to below 1.5, very good. But if it is 2.5 also, you can ask her to proceed with the pregnancy. Dr. Sarika, in hypothyroid women receiving LT4 who are newly pregnant, how often should maternal, so अब वो जो lady आई थी आपके पास thyroid पूछने के लिए, वो pregnant हो गई, so she comes to you, how often should maternal thyroid function be monitored during gestation?
In hypothyroid women who is receiving levothyroxine, her maternal TSH should be monitored every 4 weeks in the first half of pregnancy, and the reason behind this is because in the first half of pregnancy the levothyroxine dose it needs to be adjusted, and in the second half of the pregnancy it should be checked at least once between 26 and 32 weeks of gestation.
Yes. Dr. Sarika, again one more question for you. अब वो लेडी जो आई थी उसके बच्चा भी हो गया, so how should the LT4 dose be adjusted postpartum?
During postpartum period, the levothyroxine dose it should be reduced to the pre-pregnancy level, and TSH should be monitored 6 weeks thereafter in the postpartum period. But there is a recent study which says that
why could you tell me why 6 weeks?
Because
anyone.
About 6 weeks.
Yes, that is the normal postpartum period. That is okay. But why 6 weeks? When does when does postpartum thyroiditis occur? Yes.
Exacerbation.
Yes, because there's a risk of postpartum thyroiditis in these cases who are antibody positive. So that is why you repeat it at 6 weeks. Right. Yes, you can proceed, please.
There is a recent study which states that approximately 50% of patients who are suffering from Hashimoto's thyroiditis, they may require an increase in their pre-gestational dose, and this may be due to the exacerbation of the antibody-mediated their thyroid dysfunction.
Thank you, that was perfect. Dr. Archana Kumar is not there, so this question is open to all. What is the outcome and long-term prognosis when subclinical hypothyroidism or overt hypothyroidism are effectively treated through? So women with adequately treated subclinical hypothyroidism and overt hypothyroidism have no increased risk of any obstetrical complications. Consequently, there is no indication for any additional test. This question is to you. Except for measurement of maternal thyroid function, should additional maternal or fetal testing occur in treated hypothyroid women during pregnancy? There's a team here. Radiologist bhi hai, pathologist bhi hai. So team is working now. Dr. Ruby Chug will tell us what is their role.
In case of women, in case of women adequately treated with overt hypothyroidism or subclinical hypothyroidism, except maternal thyroid function testing, no other testing, maternal or fetal, is required.
Yes, so in hypothyroidism, no testing is required because TPO antibodies से कोई मतलब नहीं है, वो तो qualitative test है. आगे hyperthyroidism में important है, वो हम अभी आएंगे उस पर. So Dr. Uma Bharatwal, in euthyroid women who are thyroid antibody positive prior to conception, what is the risk of hypothyroidism once they become pregnant? एक lady आती है, वो कहती है डॉक्टर साहब मैं तो thyroid antibody positive हूँ and she is non-pregnant, तो उसको आप क्या advice दोगे?
When the patient becomes pregnant in first trimester, she is safe because the thyroid function exists. It acts as a buffer. up to first trimester. But after first trimester, she is at risk of developing hypothyroidism. Then after first trimester, we should go for TSH level, and if it is low, then we should proceed for we should give her treatment accordingly.
Right, perfect. Dr. Nishi, how should thyroid antibody positive euthyroid women be monitored and treated during pregnancy? Now,
Every 4 week in first of pregnancy and at least once in 26 to 32 weeks of pregnancy.
you have to get a TSH done. Dr. Nishi, again a question for you. Should thyroid antibody positive euthyroid women be monitored or treated for complications other than the risk of hypothyroidism during pregnancy?
In addition to the risk of hypothyroidism, TPO antibody is a risk factor for miscarriage, premature delivery, perinatal death, and postpartum problems and low intellectual and motor skills in newborn. So
Thank you. Dr. Manisha Jain, could you recently American College of Obs and Gynae have issued a guideline in 2015. So Dr. Manisha, and that sums up the whole thing which we discussed just now. So Dr. Manisha Jain, I'd like you to enumerate all those recommendations.
The recent ACOG guidelines published in 2015 are based on a large trial done in 2009, which is somewhat controversially saying that there are 7 level A recommendations according to them. Number 1, there should not be universal screening for thyroid diseases. Number 2, for screening the thyroid status of the patient, pregnant lady, TSH is the first line investigation. For diagnosing the disease, TSH and free T4 is the investigation of choice. Number 4, if a patient is overt hypothyroid, then we should treat her with adequate levothyroxine dose to reduce the adverse effects. And number 5, to monitor the dose of thyroxine, we should do 4 weekly TSH testing. Number 6, for overt hyperthyroidism, we should treat the patient with thiamides, that may be propylthiouracil or methimazole, and to decrease the adverse side effects of this disease. And to monitor the disease, we should do FT4 regularly.
Yes, thank you. Now, the take home message from this panel discussion, that is custom message, is universal screening for, this is for Indian conditions. She summed up American conditions, now I talk about Indian conditions. Universal screening for hypothyroidism during pregnancy at first antenatal visit or as soon as pregnancy is confirmed. Second trimester specific reference ranges for TSH are first trimester 0.1 to 2.5 milli-international unit per liter, second trimester 0.2 to 3 milli-international unit per liter, third trimester 0.3 to 3 milli-international unit per liter. ये तो शायद सबको रट गया होगा. Recommended treatment is levothyroxine. Thyroxine treatment for all antenatal women with subclinical hypothyroidism targeting the upper limit of normal reference range for thyroid stimulating hormone and treat all overt hypothyroidism. For hypothyroid receiving treatment, increase the dose by 2 tablets per week and TSH level once in each trimester. Then following delivery, maternal LT4 dosing should be reduced to the pre-pregnancy levels and a serum TSH assessed 6 weeks thereafter. Do you want me to cover in short iodine metabolism and hyperthyroidism also? No. So we leave it. But role of ultrasound in thyroid disease in pregnancy is important, and we have learned Kajli Gupta with us. She'll brief us with that. which women, this question you don't have to answer. Which women require additional fetal ultrasound monitoring for growth, heart rate and presence of goiter in pregnancy? This is for us obstetricians. So, fetal surveillance with serial ultrasounds should be performed in women who have uncontrolled hyperthyroidism and or women with high thyroid receptor antibody levels. Refer them to experienced maternal fetal medicine specialist or refer her to Kajli Gupta or Seema Midda or any radiologist of your liking. So only hyperthyroidism cases are the cases which require additional ultrasound surveillance to the routine one. So Dr. Kajli Gupta, when we refer women with Graves' disease with TRAB positive at least raised at least 2 to 3 fold the normal level in women at 18 to 22 weeks, what will you particularly see for and report for us?
We see all the normal routine ultrasound for the patient. We see all the gestational age, viability, amniotic fluid assessment. But in Graves' disease, specifically we look for thyroid dysfunction in the fetus. And the signs of thyroid dysfunction in fetus is presence of IOGR, any growth restriction, fetal tachycardia, reduced the presence of goiter. Fetal goiter is a very important and first sign which we can pick. It's a kind of thyroid enlargement which we see in an adult patient that we can also pick up in a fetus, and it's a very good sign. If we pick up presence of fetal goiter, it indicates presence of fetal thyroidal dysfunction. And we can also see for advanced bone age fetal tachycardia and presence of hydrops and cardiac failure.
So we come to the end. Any queries? कुछ लिखा हुआ है किसी ने किसी पैनलिस्ट के लिए?
Dr. Kajli, one question for you. You said that we patients or no?
नहीं. This is for hyperthyroidism. Graves' disease.
Graves' disease. If we know there is a presence of Graves' disease in the mother, we specifically look for fetal goiter.
Otherwise, also we can have level 2 USG in hyperthyroid patients.
In hypothyroid, you require only the routine ultrasound like any other antenatal case. In patient of hyperthyroidism with Graves' disease, you have to look for what she said between 18 to 22 weeks. So I hope we have been successful in unlocking hypothyroidism in pregnancy. I wait for your claps to show us if we really unlocked it well. Now we begin with our questions, and all those who answer it correctly, the panelists will decide who will win the prize, right? So a 33-year-old Gravida 3 Para 2 at 10 weeks. Gestational age comes to you for her first prenatal visit. She reports that she had hypothyroidism in the distant past but was never treated and is asymptomatic. So she is euthyroid, but she is hypothyroid. So physical examination is normal on and antibody positive also. So physical examination is normal. On bimanual examination, her uterus is 10 week size and fetal heart 150 beats per minute. Her TSH level is 13.1, T4 is 0.7, so TSH is raised about 10, T4 is 0.7, and her anti-thyroid peroxidase antibody level is high. The next best step in the patient's care is, first, begin levothyroxine. B, repeat serum TSH and free T4 after 20 weeks of gestation. C, measure serum thyroid stimulating immunoglobulins. Perform ultrasonography of the maternal thyroid. Yes. Now, raise your hands, raise your hands. नहीं ऐसे नहीं ऐसे आंसर कोई प्राइज नहीं मिलेगा. Raise hand unless the mic comes to you. You don't have to answer. Raise your hands. That's all. Manisha, take the mic to someone and let her answer. जिससे मर्जी आए बोलो. And no one will answer before she comes to you.
start levothyroxine at the first visit.
Yes, but that doesn't complete the answer. You'll have to give the reasons also.
Get her TSH done and repeat every 4 weeks.
We have to, because the TSH...
The answer is only, you have to choose between this, and only you have to say, not further management is not asked. You just have to pick up the answers.
Because
फर्दर मैनेजमेंट वाले दूसरे क्वेश्चन आएंगे. अभी यहाँ तो मल्टीपल चॉइस है, एक आंसर लेना है, उसका कारण बताना है.
Because the TSH level is 10, so we have to start we have to start levothyroxine as early as possible, because the level is 13. So in my suggestion, I would like to start with 100 microgram or 125 microgram per day.
So किसी को कहाँ गया वो फोटोग्राफर? आओ, डॉक्टर नीना मोहन, आप गिफ्ट करिए उन्हें. आओ अर्चना प्लीज, आओ आओ. आज तो बहुत अच्छा आंसर दिया है, तो लो. Wait. So we come to the next case. A 33-year-old woman had received a diagnosis of primary hypothyroidism when she was 23 years of age and had been taking an essentially stable dose of levothyroxine 0.112 milligram per day for at least 2 years. She comes to you for advice before conceiving. What advice will you give her? Raise hands, please, and no answers. No, this is not multiple choice. एक खत्म हो गया multiple choice now. लो, आगे से चलो, इधर से चलो. Office bearers not allowed. Last chance. Office bearers को last chance देना. अभी इस टेबल से पूछ लो, फिर पीछे जाना.
Get her TSH and T4 levels done. And start, and then only you will start levothyroxine.
हाँ. Get her TSH done and pre-pregnancy. हाँ, तो pre-pregnancy में और क्या advice देना है? pre-pregnancy में एक तो वो है, ठीक है.
She should conceive only when her levels comes to normal.
ठीक है. Below what?
It should come between 0.1 to 2.5.
Okay, below.
But in fact, it should be below 1.5 so that
better management.
Better managed later on.
और कुछ रूटीन आप मरीज को भी तो बोलते हो, जो थायराइड हाइपोथायराइड नहीं होता उसको भी तो कुछ बोलते हो लेने के लिए.
Folic acid. Start folic acid because
So folic acid supplementation 2 months before natural planned conception. This is for everyone, na? So serum TSH. Now serum TSH comes to 5.95 milli international unit per milliliter. What should you advise now? No answers and raise your hands. What should you advise now? वो पीछे. Yes.
You will have to start levothyroxine now, because we have to reduce TSH below 2.5 at least. And
how much?
TSH should be below 2.5 million units.
How much levothyroxine?
Levothyroxine we should start with the minimal dose between 25 to 50.
यहाँ पे she was already taking 0.116, 112. So
2 taps per week we'll increase by 2 taps per week first, and then we'll do the level at least 4 weekly and adjust the dose.
The answer is only we will increase it to 6 we will increase the tablets by 2 tablets per week. Right. Give her the gifts. So you increase the dose now. Then silence please. So then she comes to you on missing her periods. अब आपने उसकी dose increase कर दी और उसको सब बता दिया folic acid और वो लेनी है. Then she becomes pregnant and she misses her periods and does a urine test at home and it is positive. So she comes to you and you do it and it's positive. So how do you proceed now? Raise hands, no answers. Dr. Pragati.
check if it is within.
आप T4 भी करोगे?
T4 and TS.
क्यों?
Just to assess all her levels if they are normal.
नहीं, T4 रूटीनली तो नहीं करते, TSH से ही असेसमेंट हो जाता है. T4 तो डायग्नोसिस के लिए है ना. So
TSH.
You start with, और हाँ क्या देते हैं प्रेगनेंसी में और बताओ ना.
Folic acid and for the maintenance of the pregnancy.
Why natural micronisotestone?
For the maintenance of pregnancy.
नहीं सब में natural product, only folic acid.
For such patients, they are at a increased risk of.
If you have already made her euthyroid after adding 2 tablets, why will she have the risk? She will be like any other normal pregnant woman. That is why you are doing it 2 months before. Folic acid, levothyroxine, give her. ये तो सही बोला था कि levothyroxine देना, give her. Levothyroxine continued. TSH is checked at 8 weeks of last menstrual period. Found to be elevated to 40.75 milli international. 8 हफ्ते बाद फिर आपने TSH करा तो 40.75 मिला with a normal free thyroxine level. तो क्या, what next? Hands raised please. वहाँ जाओ पीछे. Anyone? ये इधर रुचि. Someone new.
To increase the dose. No.
Of levothyroxine, right? And then what you do?
Then you will monitor the level again 4 weekly.
4 weeks. At 12 weeks, you will again get it done.
Yeah, because after 16 weeks, normally we have to maintain the level of levothyroxine which we are given. We have to decrease.
Because it increased markedly, so you have to repeat it after 4 weeks. Because इतना ज़्यादा increase क्यों हुआ? You will be worried. So वैसे तो एक ट्राइमेस्टर में एक बार करना, पर चूंकि इतना ज़्यादा हुआ है तो you will repeat it after 4 weeks. ठीक है. और दूसरा 8 weeks पे आई है तो 12 weeks पे कुछ और भी करते हैं जो रूटीनली हर मरीज में करते हैं.
Patients where we get even level higher than this 40. Then too we cannot increase levothyroxine in such a high dose. We have to increase only by 2 tablets.
हाँ, only. And then again ऐसे केस में आप 2 weeks पे फिर repeat करा लो. 2 weekly कर दो.
Still we cannot increase.
अब अल्ट्रासाउंड हुआ, ठीक है. At 12 weeks can you give her the gift? 12 weeks. अरे एक Wednesday छोड़ दो. You find diamniotic dichorionic twins. So that was the reason why it was rising so high. So now how do you proceed? भाई एक बार इतना ज़्यादा थायरॉक्सिन बढ़ गया तो इसका मतलब कहीं ना कहीं घपला है. ट्विंस की वजह से इतना बढ़ रहा है तो अब इसका मतलब ये थायरॉक्सिन जो है TSH लेवल जो है जल्दी बढ़ेगा. तो ऐसे पेशेंट्स को आप कैसे मॉनिटर करोगे? जो आप इंडियन सोसाइटी कह रही है ट्राइमेस्टर में एक बार, पर ऐसे दूसरे केस में आप क्या करोगे? हर 4 हफ्ते पे करने लगोगे और अगर ज़्यादा आएगा तो 2 हफ्ते पे कर लोगे. बच्चों because she is dichorionic diamniotic, then बहुत irregular सा इसका TSH increase है तो बहुत ज़्यादा post retroplacental clots बनने का अंदेशा है. So post delivery labor was induced at 37 weeks in this case. Now post delivery, what do you do about thyroxine?
Wait 6 weeks then
Then you have to decrease the dose of levothyroxine and then repeat the
to decrease levothyroxine
pre-pregnancy level.
Yes.
And then repeat the test at 6 weeks.
Okay, thank you. Good. So wish you all a very happy Diwali. Everyone, please wish you all a very happy Diwali. Thank you, ma'am. Dr. Prapti requested to come here. Everyone, please come here. We are going to celebrate Dr. Prapti's birthday. Dr. Prapti, I have made a video film for you. If all can watch this, please. And AOGGIS wishes you a very happy birthday.
Thank you, ma'am. Thank you.
Thanks a lot for all your love.